Hey, I'm Jim Wiedrick. Every day I'm working to transform healthcare in Southeast BC, and one of my big ideas is to have one-on-one conversations with smart, engaged people. We're asking the question, what can we do to make healthcare better, outcomes and service improved for all the residents of our region? I'm really stoked today to be joined by Marius Scheepers. He's an ophthalmologist who works out of Trail and then serves as a surgeon from the Nelson site also. And Marius has a long track record in the Kootenays. He's also been involved in the organizing and political side of his own ophthalmology societies. And I want to welcome you in today, Marius. How are you doing?
Good morning, Jim. I'm doing really well. How are you?
Yeah, well, I am stoked again that we've gotten a whole bunch of snow. And it's looking like winter outside my door. So I think if it's going to be February the 1st, we might as well embrace the fact that it's winter for another month. That's where my brain space is at.
Nice. Time to go skiing again.
Yeah. So Marius, when we got the idea to sit down and record some thoughts, a lot of the impetus was along the lines of, how does our great big system work in the land of the specialist? Because one of the things I hear from a lot of folks who engage me on Facebook or the messaging streams is we just don't have enough specialists in our part of the world. So if we think of the West Kootenays, the East Kootenays, all the way up to the Alberta and whatnot, specialists like ophthalmologists are not exactly overflowing. So can you just address for a moment where you sort of see the rural-urban divide in ophthalmology and how our service provision is going in 2025?
Sure. I think in years gone by, let's say, 30, 40, 50 years ago, the average ophthalmologist was a comprehensive ophthalmologist that could do a little bit of everything. And because you could do a little bit of everything, it wasn't so scary to go and live and work in a rural area. But in our days, there are more and more ophthalmologists who are very subspecialized, who may, perform 90% of their work in cornea or in retina work or glaucoma or neuro-ophthalmology or pediatric ophthalmology, et cetera, et cetera. And that becomes a little bit more complex because if you move to a small area like the Kootenays, then if you come here as a retina-only specialist, you may not have enough work for yourself. And I just find there are more and more new grads that are just a little bit afraid to come and work in a more rural area where you have to be a little bit of a jack of all trades because you don't have a glaucoma specialist around the corner that can just do the glaucoma surgery for you, or a retina specialist that you can refer to, et cetera, et cetera. So that does change the landscape a little bit. And I think we're probably also not quite graduating enough specialists. And so as a result, I'm going to guess that's why we're somewhat underserved. I'm going to make one last point that I also think is kind of relevant. I think in the old days, or so-called the old days, 30, 40, 50 years ago,
Yes.
People kind of overworked themselves a little bit. And they worked 5 days a week and they had on-call and they often finished their offices late. And, they didn't have a very good work-family life balance. But the younger generation, I think, kind of have been taught better, if we want to call it that. If you have a better balance, you need greater numbers of specialists.
Because basically now patients in our Southeast region, a lot of the time they'll have to end up heading towards Kelowna or even Vancouver for some of these specialized services. Is that basically the case?
Fortunately, where we are here, I would say that we do take care of a lot of our own procedures. And certainly if you have a retinal detachment, absolutely, you will have to go to Kelowna or Vancouver for that. And I would say that's probably the number one reason we send people out. And there are definitely going to be some other procedures as well, but we do try.
And then inside the big field of ophthalmology, how is the workload or some of the hyper-specialization balance playing itself out? Do we have what we need in the different zones in BC?
That is far more complex right now and problematic. We're very short on certain subspecialists in particular. For example, neuro-ophthalmology, pediatric ophthalmology, uveitis specialists. There are very few, and there's also somewhat of a shortage in oculoplastic procedures. And part of the reason for this is that our fee guide has not been revised in decades. And so we have an antiquated fee guide where certain procedures are really grossly under remunerated, and a few procedures, one in particular, is extremely well remunerated. So it creates a very big divide between those ophthalmologists who, let's say, perform a lot of neuro-ophthalmological consultation, and those ophthalmologists who perform a lot of intravitreal injections, because you can perform a lot of intravitreal injections in one day. So some of the very busy clinics can do up to 100, some of them 120 injections a day. And so if you multiply that by the amount of money that you get paid to perform that procedure versus seeing 8 complex neuro-ophthalmological cases in a day, you're going to get paid roughly 8 times as much for performing all of those intravitreal injections as what you're going to get paid for doing the neuro-ophthalmological consult, or being a pediatric ophthalmologist and seeing children that take much longer to see, or seeing a uveitis case, because they take much longer as well. Those patients usually have many systemic conditions associated with them. You need to get a rheumatologist involved. They have complex drugs that they're taking. And so this is kind of a problem. In fact, we were approached by the medical services plan, and they explained to us that they've noticed that some of our procedures are extremely well remunerated and are utilized at an extremely high frequency, and some of our procedures are very under remunerated. And so we actually formed an economics committee. We only formed this, I think, around 2018, 2019. And this was long overdue. And we were under instruction from DoxyBC as well to please sort out our house and kind of fix this, because this is a problem for patient care and for recruiting some of these subspecialists. And so we sat down together for some years. We had frequent meetings, once a month to once every 2 months max. And these meetings would sometimes go on for hours, where we would discuss among all the subspecialists. We had a representative from neuro-ophthalmology, from pediatric ophthalmology, from oculoplastics, from glaucoma, comprehensive ophthalmologists. We had a retina specialist for much of that time, although it was more difficult to recruit a retina specialist to sit on the committee. And so we discussed this, and we came up with a really good revision where we came up with adjustments or new fee codes for 30 procedures. And we almost got this passed. It actually had received approval from MSP already, and it was going to go to the board of the doctors of BC. It had been passed by the tariff committee of DoxyBC, and then unfortunately the retina specialists were really not happy with this, because they perform many more of the intravitreal injection and anterior chamber paracentesis procedures compared to other ophthalmologists. Although other ophthalmologists also perform those procedures, they perform many more, and so they were unhappy, and as a result they sued us and took us to court, which was most.
Ooh. So I hear you saying, basically the incentive in our single payer system for people to provide services is skewed. It's not lined up well with how long it takes or how complicated things are. And we've got some high volume things for like conditions like macular degeneration with lots and lots of people have that.
Mm-hmm.
Those are paid maybe too much for the amount of time that they take, whereas these other more unique conditions that take a lot of consult time aren't paid as much. And so there's like a perverse incentive in our Ministry of Health system where some people are just going to get compensated much higher, and now there's this internal politics and struggle, and even though people are trying to make the system work better, it's been kind of blocked. A fair summary of what I just heard.
That's pretty good. That's pretty good. What we strive to do is we strive to look at the complexity of the procedure being performed versus the time that it takes to perform that procedure. And that's really what we should base our payments on. Obviously, you also have to take into account office overhead, and there'll be some other things as well. And so, I think the work that our economics committee was undertaking was extremely good and important work, and it had great support from Doxa BC and the medical services plan. But then, unfortunately, for unknown reasons, the Ministry of Health decided to sign a kind of a secret non-disclosure agreement, alternative payment plan with the Association of BC Retina Specialists. And so they now no longer paid the same way as other ophthalmologists for performing these procedures. And this creates a kind of a big problem for us, because how do we proceed now, right? Because our package, where we were trying to find better funding for the under-remunerated procedures, has now been tabled indefinitely. We don't know the details of this non-disclosure agreement, and really it's widened the divide between those ophthalmologists who perform this procedure very frequently and those who don't. And this is also, I think, a big problem in rural areas, where we live, because we have two great retina specialists or ophthalmologists with an interest in retina, and who've got retina fellowships, who come from Kelowna to come and perform these procedures for our patients here in the Kootenays. And we greatly appreciate, and I think they're both really good physicians. But the problem is that their clinics are extremely full. And I have patients who come to see me and they tell me, Dr. Scheepers, I can't get in to see the doctor who normally, performs these injections, because they say that their clinic is full. They're asking me to come to Kelowna to come and see them. And they already ask every new patient to come and see them in Kelowna for the first time. But these are elderly patients. Many of them have great difficulty traveling to Kelowna, especially in the winter. And so this is burdening our patients and burdening our system. And one of the physicians who come from Kelowna to perform the procedure, I know that he's trying to find help to get somebody to come and help him in the Kootenays, but he's struggling. He can't find somebody. And there are other ophthalmologists who can perform these procedures, comprehensive ophthalmologists, who are not part of the Association of BC Retina Specialists. In fact, there's a doctor on the island that I know well, who's part of the executive on our society. In fact, our current president, who performs many of these procedures, but he does not receive the funding for the drug from the PHSA, from the Provincial Health Services Authority. Either he has to pay for the drug out of his own pocket in order to administer it for his patients, or he has to pass on the cost of the drugs to the patient. Because you see, the Association of BC Retina Specialists have established this contract. It's called the Provincial Retinal Diseases Treatment Program with the PHSA, where they are the sole providers of this drug and the sole administrators of this through the program. So all the other ophthalmologists, including pediatric ophthalmologists who use the drug for babies with retinopathy of prematurity, all of the rest of us are excluded from this program. And so it creates this two-tiered system that really contravenes the Canada Health Act, because there's meant to be equal opportunity for all patients to treatment. And I would argue equal opportunity for doctors to provide treatment. And so for me, to be honest with you, I feel really demoralized by this, because we were promised by the Ministry of Health, and I'm not going to mention any names, but we're promised by high up people in the Ministry of Health that they would not do this. They would not hamstring us and prevent us from being able to make sure that the procedures which we perform are well remunerated. And then the next thing we heard, and I heard from a colleague of mine that I didn't even hear from the Ministry of Health. I heard from a colleague that there was a secret non-disclosure agreement being negotiated, or that had been negotiated and signed with the Ministry of Health, to exclude all other ophthalmologists from getting this drug and from being able to administer this drug under the program. And I know the other ophthalmologists are extremely upset by the ones who perform this procedure, because they were promised that they would get access to the drug, and there was kind of an admittance, at least in a verbal admittance from the Provincial Health Services Authority and from officials within the ministry, that they understood that this drug was being given by more than just Association of BC Retina Specialists, and we were hoping that that they would improve healthcare, but they didn't, in my opinion.
So we already have access issues. This is for a condition, variations of macular degeneration, that you'd need an injection every month on an ongoing basis. Mm-hmm. And now we have some backroom kind of dealings that are making it even harder for people to access the service that they need, unless you live in Metro Vancouver or a very geographically dense place where there's lots of people.
Exactly. In the cities, I think it's far less of a problem, but the rural areas suffer. And also, you might remember we started off this conversation talking about how we have so many more specialists now only doing a bit of this or only doing a bit of that, and fewer comprehensives. And government, the Ministry of Health, basically going, we're only going to fund intravitreal injection procedures for macular degeneration and for retinal vein occlusion, and for specific vascular conditions of the retina, for a select group of ophthalmologists, when the Royal College of Ophthalmology, right, in fact, the Canadian Royal College of Surgeons, they define this procedure as a core competency for all ophthalmologists to be able to perform. I started doing this injection when I was a senior house officer, or a house officer in South Africa, and I was performing intravitreal injections of ganciclovir and antiviral treatment for patients with cytomegalovirus retinitis. And so I started doing this procedure back in 2003, basically as a junior resident, or the equivalent of a junior resident. And I performed this procedure when I lived in England. Lived and worked in England, and I performed this procedure still from the first month that I arrived in the Kootenays. And really, what they're doing is it's not inclusive. It's not advancing ophthalmology. It's not working on our relationships. It's caused such a divide between this small association of retina specialists who perform this procedure more than the rest of us. And it's just sad. It's just sad.
So is this a BC unique problem, or is this something where other provinces would have the same issue going on at this?
This is very, very much a BC problem. It has been a problem in some of the other provinces as well. but it's been addressed in many of the other provinces. I think maybe even all of them. So, for example, in Alberta, they had the same problem. They went through the same thing with a massive kind of friction between the retina specialists and the rest of ophthalmology. But they readjusted their fees. They came to an agreement. I believe government worked collaboratively with them, and they fixed the problem. And so, I'm really hoping that we can still salvage things in BC. But at the moment, when you have a non-disclosure agreement, where me as past president and the current president of the British Columbia Society of Eye Physicians and Surgeons, I don't really know what's in that agreement except for what's been leaked by others, and we have broken promises that were made by the Ministry of Health, and we were effectively excluded. And not only were we excluded, but the doctors of BC, as our union, were excluded as well. And all of this was negotiated outside the physician master agreement. And so, it's like many of my colleagues have said to me, don't we need to work together? Don't we need to hold our elected representatives accountable? And yeah, I'm disappointed, I must say.
They talk about sunshine being the best disinfectant, and I can see how a bit of transparency is absolutely required here. Do you think that this has more to do with, like I heard you say, elected representatives, or is this actually like upper levels of the actual Ministry of Health, more sort of appointed people? Like, could elected representatives help fix this problem, do you think?
Well, I really hope so. We've written numerous emails to the Honourable Minister Josie Osborne, our new Minister of Health for BC, and she has not responded herself. She is, that this appears to have been handed over to Mark Armitage, who was also the main contact that we were dealing with last year. And so I really do hope that this will receive some attention, that we will have transparency. We've asked to see a copy of the document, but this has not been provided. We've asked the doctors at BC to please request a copy of the document on our behalf. So far, I've not had a response to that question. Really, really, my concern is, I think I love my job. I love ophthalmology. It's so rewarding to help to restore patients' sight, and these are often vulnerable patients. You're so dependent on your sight, and so I think there's so much we can do to make it better. There's so much we can do to work collaboratively to improve eye health in BC and in Canada. And so when I see this happen, it's demoralizing. So yes, absolutely. I hope that we can get Minister Osborne to respond to us directly, to find out what's going on, to shed light on the program, to help the rural areas to get the care they need for this, to allow equal access to the drugs, to allow equal fair remuneration for the procedures, to help, because we were going to allocate, I think, a very reasonable portion of the funding that was being used for these intravitreal injections. We were going to reallocate to neuro-ophthalmology, to pediatric ophthalmology, to uveitis procedures, to the underfunded procedures, to improve the service provision for those ailments. And we looked at the fees across Canada in order to compare, in order to try and find a reasonable fee. And we mentioned on multiple occasions to the Ministry of Health and the Medical Services Plan that we were willing to negotiate what was a reasonable fee. But instead of negotiating that and including us in the negotiations, we were excluded. And now there's an alternative payment plan and a two-tier system, and the drugs are not being funded for
Is
all.
the motivation at the core, kind of medical politics and holding on to certain procedures, or are there some other driving factors that maybe aren't immediately apparent on the surface that you've analyzed?
I don't know. It's really hard to tell because logically you would think that the doctors at BC are a union. The Ministry of Health is interested in providing safe, good, fiscally responsible healthcare, presumably under a transparent system. The physician master agreement is put in place for a good reason, and there are these governing structures. The drug that's being injected, Avastin, is a pretty good drug. I would say there are newer drugs, we know that, and they do last longer, and you don't need the injections as frequently. But most of the world uses Avastin as a first-line treatment. And then when that fails, we move to second-line treatments. And so I think that we could roll out a fiscally responsible program where all ophthalmologists have access to this sight-saving drug. And we can say, hey, we're going to start with Avastin. If that doesn't work, we move to a second-line drug. You can choose which one that might be. And we can establish a fair and safe protocol. I, myself and others, suggested this to ministry last year. But for an unknown reason, they have not chosen that path. They have chosen this non-disclosure agreement, and they've cut the rest of ophthalmologists out. And they've we can no longer, they're the mechanism for readjusting our fees to underfunded fee codes, it's just gone.
I'm really sympathetic with the frustration because I know in my years in medical leadership, if you see a problem, you reasonably bring in all the stakeholders and you say, what can we do to fix it? Then you want that satisfaction of actually making the fix, of seeing the fruits of your labor. And what I hear you say is somehow that process got thwarted, and now actually it might even be worse on some levels than before, and that we don't have the ultimate outcome fix for people to get better access and easier pathways to get the regular, consistent medical treatment that they need.
Yep.
Don't like to hear it. Well, hey, so I've done this with other guests, and I've said, all right, I'll give you a magic lamp. Ask for a couple of wishes if you want from the genie. What is on your 2025, 2026 genie list? Like if you could fix the system, and we've done a good job of outlining how apparently this one issue absolutely needs to be fixed. What
Yep.
else would you want fixed?
Yeah. So for this particular issue, I would want transparency from government, good communication. I would want the doctors at BC, the British Columbia Society of Eye Physicians and Surgeons, and the ministry to sit down at one table. And if we need to have an arbitrator or mediator there, fantastic, no problem. And really, I think for me that's it. I don't want to rub the lamp and get cash. I don't want to rub the lamp and magically people get well, because it's just not realistic. All we need are people who care and people who are willing to be logical, reasonable, transparent, and with the main goal of helping our patients in a fiscally responsible way, having well-trained doctors. I think all these things are easily achievable, but unfortunately, I get the feeling that we're corrupted by the wrong incentives. we we don't understand things 100% because, I got the feeling that government wanted to save money because they can control the Association of BC Retina Specialist Doctors. They can control how much money they give them to spend on the drug, and therefore they can control what drug is being used. But that's not how you do medicine. You don't do it that way. You go, what's the cost? What's the benefit? How do we do this in a fiscally responsible way? Who's qualified to do this? How do we work with the governing bodies? How do we do this in a transparent way? All these things. So that's what I would ask the genie for. I'd ask them for transparency, fiscal responsibility, cost versus benefit for a particular procedure, risks, et cetera, right? Just logic. All we need is reasonableness and logic, in my opinion.
Amen. Yeah. Hey, thank you for your passion, for your advocacy, and thank you for taking the time to, kind of review a thing that we could maybe put some effort into actually fixing. So I definitely have my fingers and toes crossed that 2025 brings us that fix.
I
Thanks,
would love
Marius.
that. Thanks very much, Jim.